Hey guys, wanted to talk a little bit about asthma prevention and management today. And this is a PowerPoint actually developed by the CDC that can be used for asthma education and teaching. So, what is asthma? We know asthma is a chronic disease of the airways, and the key symptoms that we see with asthma are wheezing, shortness of breath, tightness in the chest, and that nocturnal cough or early morning coughing. And these are the questions that we ask with our patients that are asthmatic when we're trying to determine if their asthma is being well controlled. And so we know that asthma episodes, the acute episodes, are usually reversible with a bronchodilator, but we also know that recurrent uh, asthma exacerbations and frequent asthma exacerbations can cause long-term airway remodeling, and that actually leads to some irreversible damage and COPD later in life. So the key is to both prevent asthma attacks as much as possible and to control them with medications. And so the key components of asthma are threefold. We have airway inflammation, and if you look at the picture of the asthmatic bronchiole on the right, you will see that the blue lines are smooth muscle bands that are contracting, and so we have that bronchoconstriction where the airway narrows, and we also have a swollen mucosa there, and so you see the actual lining of the asthmatic airway is swollen and puffy. That's the pink area. And then there's also mucus production in uncontrolled asthmatics. So we have the three things that go along with asthma noted in that picture: bronchoconstriction, airway edema, and the mucus production. And when you look at that picture, just think about the mainstay of asthma treatment, and the bronchodilators will reverse that airway bronchoconstriction because they are smooth muscle relaxants and they'll bronchodilate. And then the inhaled steroids that we use to control asthmatics get rid of that inflammation and the mucus production. And so, just a bit about epidemiology. Asthma affects 25.7 million people, and for pediatrics, particularly 7 million children under the age of 18. So this is a big number of visits to the emergency room and also to the primary care setting. So you'll be seeing a whole lot of asthma in the primary care setting, really no matter where you're working. Just a bit about race and ethnicity. We know that um, African American and black children, particularly boys, are the most difficult to control as far as they have the highest morbidity of anyone else with asthma. And so, just looking at the prevalence by race and ethnicity here, you see clearly that the number of black individuals with asthma has been always been ahead of white and Hispanic, but over time continues to increase at a greater velocity in prevalence. And so, what causes asthma? Well, we know there's a genetic component to asthma, and really that genetic component is the allergic or atopic predisposition. And so, when we have a family history of atopy or allergy, then that can be in the form of allergic rhinitis, severe eczema, food allergies. It's that whole atopic component. We know that asthma is very closely affiliated with that. So we have a genetic component, we have occupational exposures, and certainly people that are exposed to asbestos and chronic indoor pollution from environmental, occupational exposures, and then also environmental exposures, tobacco smoke, different pollutants in the air. These are all type of things that are triggers for the development of asthma. So if you have the genetic component and then you're put in an environment that also has some of these known triggers for asthma development, then that's kind of a double whammy for the development of asthma. And we're going to talk about some specific environmental exposures that are associated with allergy and asthma exacerbations that we can educate our parents to reduce exposure to in the children. So again, atopy or atopic conditions. This is just the body's um, overreaction of an antibody, specifically the IgE, in response to environmental triggers. So this could be dust mite, this could be specific foods they're allergic to, this could be mold, grass, weed, tree, pollen. And so basically, people will have that are allergic will have specific antibodies that are elevated, immunoglobulins, um, in response, floating around in their bloodstream to specific antigens. And so you can actually draw blood, and this is called RAST testing. It's a specific type of testing, and you can draw and check specific IgE levels for mold or for peanut or for dog or cat, anything that you're wanting to test. And that is one of a twofold measure of testing for allergies. You can do the allergy skin testing, and you can also do a specific IgE for different allergic triggers. So again, the atopic conditions are allergic rhinitis, asthma, and eczema, and also food allergy. These are all quote unquote atopic or allergic conditions. And so, one of the things we want to educate our families on, the number of people that are allergic to dust mites is extremely high. So, if we have asthmatics or even just severe allergic patients, there are a couple things you can do, just general hygienic things to recommend to our patients to reduce exposure to house dust mites. And, that includes washing bed linens frequently, using hypoallergenic pillows, and keeping everything just really clean and the number of dust particles off of them. So everything needs to be washed and laundered, and also maintaining a good humidity, and 30 to 50% is the recommended humidity level. Also, wrapping the mattress and pillows in the vinyl encasements help reduce the exposure to dust mites. And certainly, if we can have hard surface floors instead of carpeting, which we know carpet is just a magnet for dust mites, even if they're vacuumed frequently, it's hard to get all of the dust mite allergens up. So, we recommend hard surface floors over carpet. And then another thing that is a very known trigger to allergy and to asthma exacerbations is cockroach dung. And so it's actually the feces of cockroaches that are that increase the likelihood of developing asthma in children that are chronically exposed to cockroach dung. And so, what we want to do is try to keep things as cockroach free as possible. And one of the ways to do that is to keep everything clean, keep food picked up and away. Boxed up and contained, and then also to keep avoid having wet areas and water, standing water, which also attract cockroaches. Um, Anyone who is allergic to pets should obviously not have them in the house, and for the families that just refuse to put their pets outdoors, if they have children with allergies or asthma that are allergic to their pets, they definitely need to stay outside of the child's bedroom. Also, mold is a very significant allergen and a trigger for recurrent asthma exacerbations. Both dust mite and mold are year round, so they're not seasonal problems. They are perennial problems. And so by keeping everything dry, keeping the humidity between 30 to 50%, and eliminating any kind of moisture problems in the home, particularly in mobile homes, a lot of times water will seep or flow underneath mobile homes, and so those tend to be a harbor for mold. So make sure that our families are reducing anything that will lead to mold exposure for the child. And then other triggers, obviously, we can't do anything about grasses, weeds, trees, but it is good to keep children inside if they are allergic to grasses and weed and pollen. Keep them inside while people are mowing, um, in low, close proximity to their home. We don't want to keep them inside all the time, but certainly if people are actively mowing outdoors. And then air pollution is something we all need to be working towards minimizing, because it really does play havoc on children with and adults with asthma. And so, the 6 key messages from the CDC's asthma task force: inhaled corticosteroids are the drug of choice for long term management of asthmatics. And the key with the inhaled corticosteroids is that we want to manage the child on the lowest dose possible that will prevent them from having to use their inhaler more than 2 times a week, or then having symptoms more than 2 times a week. So there's some specific guidelines for asthma management and medication management that we'll talk about at a different time. But inhaled corticosteroids are the drug of choice. And then every child should have an asthma action plan, and we will talk about those as well. And that's just what the family can use at home to make sure that they know what to do in times of worsening symptoms or an acute asthma attack. And then we want to manage the severity of the asthma, and we know that it is a much better situation to remain on a low dose inhaled corticosteroid, which are in microgram doses and topical, and at minimal exposure or uh, systemic absorption, compared to if we have to use frequent bursts of oral steroids, which are in milligram doses and are systemic. So we want to decrease the severity of asthma exacerbations, and again, that will help prevent that long-term airway remodeling that is irreversible that we see in individuals that have recurrent asthma exacerbations. I also want to make sure that we are managing them at the right level of asthma, whether they're mild, intermittent, or all the way up to severe, persistent asthmatics. We want to make sure that we have them on the right medication regimen, and that we are following up frequently and constantly educating about ways that they can decrease exposure to allergens. And that includes having them screened for allergies by referring to an allergist if they are having to remain on inhaled steroids for control of their asthma. We really need to find out exactly what their allergic exposure, what we can control in their environment. So, a lot of times, if people know exactly what their child is allergic to, they can either do desensitization through allergy shots or allergy immunotherapy, or they can try to be really diligent in avoiding those specific allergic triggers. But the majority of children with asthma have an allergic component or allergic trigger to that asthma. So we want to find out exactly what they're allergic to. So I do not hesitate in referring to an allergist for allergy evaluation in any child that's having to remain on inhaled steroids long term. So how do we diagnose asthma? Um, Certainly, I want to point out that we are very cautious in diagnosing young children with asthma. Children that have viral infections, such as bronchiolitis, early on in life, may continue to wheeze for several years after that. So, pulmonary function testing, which really can't be done accurately until about 5 years of age, but that is the gold standard of getting an objective measurement of lung function and an objective diagnosis of asthma. But we also want to look at the history, and again, the coughing, shortness of breath, wheezing, chest tightness. These are all part of the diagnosis of asthma. And so, specific questions you want to ask about is that nocturnal cough. Are they awakened at night by their cough? Do they cough or wheeze after exercise or physical activity? Are their symptoms worse during the spring and fall or specific seasons? And do they have quote unquote recurrent bronchitis, which the vast majority of time people that have recurrent pneumonia or recurrent bronchitis, these are really exacerbations of asthma that may not have been diagnosed as asthma yet. And also, a key component to this is, does um, the wheezing or do the bronchospasms improve after medication such as albuterol or Xopenex is used? So, is it a reversible type condition? And so, often you will hear wheezing when we're listening to someone who's having an exacerbation, but I do want to point out that we have to be moving air in order to hear wheezing. So wheezing is just a sound that we're hearing when the air is traveling through those swollen, narrow, constricted airways. And so if they are not moving much air, then you may not hear wheezing at all. A lot of times we'll hear this increased expiratory phase. So instead of the normal inspiration and expiration, you'll hear a prolonged expiration because it's taking longer to blow out all of the air through that very narrow airway. And then a lot of times you'll also have the allergy symptoms, nasal sniffing, sneezing, nasal secretions, and associated allergic conditions such as the eczema, or allergic rhinitis. And so, spirometry or pulmonary function testing, again, is how we diagnose asthma, and we can look specifically at the FEV1, which is how much air they can blow out in 1 second, and then we do a bronchodilator, such as albuterol, and you repeat this spirometry, do a pre and post bronchodilator. And if they improve in that FEV1 between 12 to 15%, then that is diagnostic of asthma after the bronchodilator. So somebody without asthma may have a small improvement after they do an albuterol nebulizer treatment. But somebody that has asthma, especially not well controlled at that time, they're going to show a significant improvement after a bronchodilator. And so that gives a good objective number of what they looked like before the bronchodilator and then after. And that is how we objectively diagnose asthma. And so it's important to make sure that our patients understand the two different types of asthma medications, meaning the long-term versus the short-acting or quote-unquote emergency inhalers. So if they have an inhaled steroid in a meter dose inhaler and they also have a bronchodilator, their albuterol in their meter dose inhaler, then you need to either label those or some way make sure, have the patients demonstrate to you which ones are their everyday inhalers and which one is their emergency inhaler, because this gets very confusing for patients. And so it's also important to make sure patients understand that the everyday inhaled steroid is not to be stopped when their symptoms improve. And so what happens is patients start feeling better and then they become non-compliant with their medication because they think that they're doing well. But truly they're doing well because they've been taking their inhaled corticosteroid as prescribed. So you want to make sure that they understand what medications they are taking and what they are for and which ones are long-term. But essentially the inhaled steroids are used to decrease that inflammation and the mucus production. And then the long-acting beta agonists sometimes have to be used in addition to the inhaled steroids. These are medications such as salmeterol, or Advair has the inhaled steroid plus the salmeterol, so it's a kind of a two-in-one medication, and basically the long-acting beta-2 agonists will hold the airway open just as if they were taking albuterol, but instead of a 4-hour medication effect like albuterol, the salmeterol, the long-acting bronchodilator, um, will cause the bronchodilation for up to 12 hours at a time. So this is for more moderate and moderate persistent asthmatics that are having to reach for that inhaler, their emergency inhaler, um, greater than greater than 2 times a week, even when they're already on an inhaled steroid. Leukotriene modifiers such as Singulair are also a good long-term anti-inflammatory type medication. They are not steroids. They have less side effects of steroids, but they are also a more mild control of the asthmatic symptoms, and they take about 4 to 6 weeks to start working um, at their full potential. So again, the short-acting beta agonists such as albuterol or Xopenex usually hold open airways for about 4 to 6 hours. You want to make sure that your patients can return and demonstrate how to use a meter dose inhaler. And also we want to point out that really we need to have our patients using some sort of a spacer, such as an aero chamber, in order to fully get the benefit of that meter dose inhaler, because we know that if not, the vast majority of the medication is spraying directly on the posterior pharynx and is swallowed by the patient. And so the albuterol or short-acting medication or the inhaled steroid is not doing any good in the stomach. It needs to be inhaled in the lungs. And so we want to make sure that our patients are using the MDI properly and also using a spacer. And so most insurances will pay for a spacer, and you'll want to include a prescription for a spacer. And this will really help get the medication where it needs to go. Nebulized medication such as albuterol and Xopenex via a nebulizer is always a better way to treat an acute asthma attack, because the particles are smaller and nebulized, and they're carried in through with the saline down to the lower airways. Now, if the child is not having an acute asthma attack and they can take a deep breath, there is not any evidence that a spacer does not also do this. It's really just when they are having that acute attack and cannot take a big deep breath inhale that the nebulizer would be the treatment of choice. And then also in very small children, we can use masks with the nebulizers. It's just hard for them to coordinate that breathing in and out and utilize the spacer. So we want to maintain normal activity levels, and I always tell patients that feel like they can't do sports and things, that there are a lot of Olympic athletes that have asthma that is well controlled enough for them to compete in the Olympics. So if we can control asthma to that degree, we can certainly control our patients' asthma well enough for them to participate in PE and childhood extracurricular sports. So we want to prevent asthma exacerbations, and we want to obviously prevent asthma ER visits and hospitalizations. And so the asthma action plan, every one of your patients that has asthma should have an asthma action plan. This is a sample of an asthma action plan, and they are developed to be user-friendly and understandable for young children. And this is one for ages 2 to 5, and everything is in a red, yellow, and green, just like a traffic light. And so in the red zone, this is 50% of their normal lung function or their peak flow. 50% down to 0. And so this is when we are really intervening and we are calling for, medical attention. The yellow zone is that caution zone, and this is 50% to 80% of their normal peak flows. And then the green, this is when we're starting to add on additional inhaled bronchodilators to start to kind of relieve symptoms. Sometimes this is when we have a secondary cold or viral infection or a high pollen count if we're allergic to pollens. And then the green zone is 80% and higher, and that means they are good to go. And so you will have an individualized plan for your patient with their own personal asthma action plan. And in order to do this, they have to have their own peak flow meter. So what is a peak flow meter? Well, this is something, again, that insurance usually pays for. And this is the best way for a patient to manage and assess the status of their asthma at home. And so, particularly for children who aren't very good at describing their symptoms and telling parents how they feel, and also if we're having a lot of allergy drainage and cough secondary to the allergy symptoms, it's hard to tell if that cough is coming from the child's asthma or if it's coming from a cold or allergic rhinitis and postnasal drainage. And so the peak flow meter is an inexpensive and easy way to assess this at home. And so in order to have an accurate picture of what a child's peak flow should normally be, we need to have them come in with a record of their peak flow readings during a good healthy time. And so you'll have them record their peak flows, and they'll do three trials of the peak flow and record their best one each day. And they'll come in and you'll develop an asthma action plan with that patient. And so they will know their personal best, and then you'll take that personal best and fill out their asthma action plan based on their personal best. And so, just for example, if their personal best was 200 for that child, and again, you'll look at peak flow readings and you'll compare this to other children, their gender and their height. So peak flows and normal peak flows and what a child should be able to blow in their peak flow meter is dependent on their gender and their height and their age. So you can give them a peak flow chart and have them circle it, or you can have them record it like a calendar. But when they bring that in, then you'll be able to take, if their peak flow is 200, let's say, then 80% of that would be 160. So you'll fill out that between 160 and above, they're good to go, just doing their current treatment. If they're at 50%, which would be 100 to 160, they're in that yellow zone. And so that's when they're going to have to start adding their albuterol or Zopanex every 4 to 6 hours, and maybe manage any allergy medication, start taking Zyrtec or Benadryl or whatever it is they manage their allergic symptoms with. And then certainly if they are below 100 and cannot blow greater than 50% of their expected peak flow, then that's when they need to call you and seek medical attention. So what do we do for a severe asthma attack, and how do we know that a child's having a severe asthma attack? Usually they are kind of hunched forward in that tripod position, which facilitates the ease of breathing. They are breathless at rest, and they are speaking in words and not able to talk in complete sentences. They are agitated and irritated and usually anxious. And their peak flows, we usually say 50 to 60 would be generous, but if they are having these symptoms and can't blow below 60%, then that is definitely an indicator of a severe asthma exacerbation. So how how often are we going to see kids with asthma and be the one managing their asthma? Well, if you look at a classroom of 30 children, on average, three of those children are likely to have asthma. And I just wanted to point out that the school system is definitely plays a role in this asthma management. And so we want to make sure that we're filling out all the paperwork that is required for the public school systems to allow children to have their albuterol inhalers at school. If a child's having an acute asthma exacerbation, we do not want to have to wait for their caregiver to have to bring their medication in. We want their albuterol and a spacer at the school, and they need to have an asthma action plan at the school as well, so that the school nurse or administration know how to manage acute exacerbations for these children. So that's kind of asthma in a nutshell, and we'll talk more about specific asthma medications and dosing with the pharmacology lecture for asthma.